Professor Rabii Madi is a world-renowned urologist who stands at the forefront of urologic surgery in the Middle East, a surgeon whose work has profoundly shaped the field of robotic-assisted techniques across the region. With a career rooted in excellence and driven by innovation, he currently serves as the Director of Urological Robotic Surgery at Cleveland Clinic, Abu Dhabi. There, he has performed over 2,500 robotic surgeries, including complex prostatectomies, nephrectomies, and intricate reconstructive procedures that were once thought impossible through minimally invasive means. His expertise lies in urologic oncology and robotic surgery, two fields that he has spent years developing, advancing, and teaching. He has pioneered surgical techniques that have enhanced the precision of cancer treatments, reduced postoperative complications, and shortened recovery times for thousands of patients. Yet for Professor Madi, innovation is not enough on its own. He believes deeply in a multidisciplinary approach to treating urological cancers and in the critical importance of integrating both clinical and translational research into day-to-day surgical practice. With over 50 peer-reviewed publications and more than 150 presentations at international medical conferences, he has become a global voice for the evolution of robotic surgery. Through his work, the boundaries of possibility in urologic care continue to expand, offering not only better treatments, but also renewed hope to patients and practitioners alike. His legacy is one of leadership, innovation, and an unwavering pursuit of excellence. Among the many honors he has received are the National Cancer Institute Travel Award, 2004, the Mentoring Excellence Award from the Medical College of Georgia, 2019. He currently sits on the board of directors of the American Urological Association, Southeastern Section. In addition, he has contributed as a scientific reviewer for the U.S. Department of Defense's Prostate Cancer Research Program, a testament to his recognized expertise on both national and international stages.
Good afternoon. Thank you very much for the nice presentation. It's a great honor for me to be here among friends, colleagues in my home city, Tripoli. I'm very proud to be back home. Actually, I live 5 minutes away from here. It's a privilege for me to be here. Thank you very much for the invitation. I would like to share with you a very specific topic that I'm really excited about. It's about the past, present, and the future of robotic surgery. For those of you who are surgeons here, they know what I'm talking about. Robotic surgery is evolving. There's integrated now AI. Who knows what the future is going to hide for us. So let me start first. When we hear the word robotic, what does it mean? The word robotic comes from actually Eastern European or Russian words called robot, или robota. For those of you who know Russian, they know what that means. And actually the word robot came from this gentleman who was a writer, a Czech Republican. He wrote a novel in 1938 about workers who are machines, who are abused in their work environment and then rebelled against the humans. And those workers or robots were the initial of the word robot. So robot is worker and work. But let's talk now about the surgical robot. How did the surgical robot start? The first attempt of a surgical robot was in 1985. This is an industrial machine at that time. It was not a medical machine. It's called Puma 200. And a neurosurgeon modified this machine to take a brain biopsy. You can see how dramatic this picture is, but this was the first attempt of any robotic intervention. Now, the urologists were the next wave of innovators, and in 1988, the urologists modified the same industrial robotic arm, and they tried to create a TURP machine that does robotic. It was unfortunately a disaster surgery at that time, and it was abandoned, but you can see how it looked like. In 1992, the FDA approved the first robot. It's called Robotic. Actually, it's used till now. As you can see it there, it is actually a bone stabilizer that the orthopedic team used to do bone surgery. Now this is in the early 1990s. You know, the surgeon here know that in 1990s, laparoscopic surgery, traditional laparoscopic surgery boomed. And we all know the limitation of the laparoscopic surgery. So at that time, in 1991-92, there are 2 US entities who are interested in developing telesurgery. Think about it right now. Right now, we are talking about telesurgeries, but that was done in the 1990s, where the NASA and the US Army, they were interested in remote telesurgery for obvious reason, right? They want to operate on astronauts from space, and the US Army, they want the surgeon to do telesurgery or remote surgery for the soldiers in the combat field. So they sponsored the grants for surgeons to develop a telesurgery model. At that time, it was not possible, but those surgeons who went through those clinical trials, they start adopting this technology that they developed in the operating room and trying to do remote surgery within the hospital itself, not across continents. So in 1994, the ASOP approved endoscopic system. The ASOP basically is a voice-activated camera, and actually in my fellowship, I used it. You talk to the camera, you give it order, you tell the laparoscope, move right, move left, and they follow the voice command. But the modern robot developed in 2001, it's called the Zeus surgical system. As you can see here, is very similar to the current robot we have right now. You can see the surgeon sitting behind a console, moving the robotic arms remotely. This was in 2001. This is the time where the Da Vinci Intuitive company came. So Intuitive bought that robot, bought that company, and killed it in order to remove any competition. And the era of Intuitive or Da Vinci robotic surgical system started at that time. 2003, this is the first robot that came with the idea it eliminates the laparoscopic compromise, and it was developed later on. This is the first robot. Actually, in 2004, I was trained with this robot. And every 5 years, they were adding a new system. It kept on evolving. I use all those systems. The latest one that we have right now is the Da Vinci 5, which was released only like a year ago. And the single port, I'm going to talk about that. But as you can see, every 5-6 years, they were releasing a newer version that will add more capabilities. And everyone was talking only about Da Vinci surgery till 2020, because at the end of 2018, Intuitive, they lost 20 years of patency. You know, those companies, they had 20 years of patent. No company in the world had the right to develop a clinical surgical robot beside them. So after that, now we are seeing lots of robotic surgical system booming. So many robots now in the market. Last year in the meeting in 2023, actually, there was 46 plus robotic surgical platform being at the exhibition. And this year is going to be even more. So why we are, as surgeon, moving to robotic surgery? Because robotic surgery, it's really overcome the limitation of laparoscopic surgery. You have high-resolution 3D imaging, you don't have tremor, you have multi-degree range of motion, and you don't have fatigue. I can do 3-4 robotic surgeries a day, and you feel fine. And if you don't believe in it, this is the data. This is the data, and you see how it's evolving along the years. Urology, general surgery, gynecology. Actually, general surgeons right now are using more robotic surgery than us, urologists, but it keeps evolving. And those are the numbers. More than 2.2 million cases are being done every year in the world using different robotic surgical systems. Most of those cases are done in the US. Around 2 million cases or surgeries or procedure robotic is being performed every year. And of course, the application is not only in urology, and we have different platforms. I'm going to briefly talk about it, but it's being used for neurosurgery. It's being used for, of course, what we call robotic visceral surgery, like we do for intra-abdominal surgery, for orthopedics, for endovascular, for endoliminal, and of course, the nanorobot. Because of that, now we're having classification, because now the field of robotic in medicine is becoming very diverse. So in order to make it more standardized and in order to have a more practical decision-making when it comes to purchasing stakeholders, There are classifications of the robot right now, which is very basically classified into 3 levels based on architecture of the robot. It's either a flexible robotic or rigid robot. It's either a single port when you have only one incision and all the instruments go through one incision, or multi-port system. And it could be a modular cards. Every part, the robot will be different pieces or one piece, etc. Let's talk briefly about the Da Vinci system, because this is dominating the surgical robot. It has more than 20 years of dominance. We have multi-generation, as I told you, was approved in 2000. The advantage of robotic surgery, the Da Vinci system is well proven now for many years. It has a strong track records. It can do multi-quadrants, so you can go from the upper abdomen to the lower abdomen with a single move, high magnification, articulated instruments, well-proven, effective robot. The problem with it, though, it's expensive. It's expensive to buy. It's expensive to maintain. The consumables, the instruments that you are using are expensive, around $2,000 additional dollars per case for every procedure. That's what it's limiting its scalability and accessibility. It's available actually in Lebanon for probably more than 12 years now, I think, or maybe 20 years. More 20 years. But few countries in the world actually besides, US and Europe and some Middle Eastern countries have it. And that was limited. So when we talk about Da Vinci system, this is the beast of robotic surgery. The Da Vinci Xi has been here for 10 years. It's not new anymore, but still the most used, I think the most powerful robot that I currently use and many others use. Now, the single port, I need to talk about it because this is going to be another development of robotic surgery. So as you can see here, the single port system, you make a single incision around 2 to 3 centimeters. Through that incision, you introduce a port, a trocar, and the robotic instruments will deploy through that single port. So you have the scissors here, you have the progress, bipolar instruments camera, flexible camera. It's a very powerful system. However, it's also expensive. And the problem with it, it will not replace the Xi system. So you cannot buy this one alone. It has to be an addition to the multi-quadrant Xi system, which will be limited. A great system, however, for narrow spaces, for small spaces, and for intra-rectal surgery. This is the Da Vinci 5. That Da Vinci system was released less than a year ago. It's, of course, a upgrade from the Xi system. The main advantage of this system, it has haptic feedback. So you can feel the tissues. One of the disadvantages or the criticism of the traditional robot that you don't feel the tissues. This one will allow you sometimes of haptic feedbacks. Also, it is more ergonomics. It has much stronger computing power, of course, than the Xi, which is 10 years old, which means it's fully ready to be integrated with AI, with augmented reality, and with telesurgery as well. It's now being used in the US at a gradual basis. Let's talk about the competition. What are now the competitors of the Da Vinci system? Those are the systems available. I heard this one also is available in Lebanon as well. The CMR, Cambridge Medical Robotics, they have their system, it's called Versius. The Versius is a modular system, which means every arm is separate. You can attach them, you can join them together. You move the robot through a joystick. It is a open system, so there's open console 3D vision. It's cheaper than Da Vinci. The problem with this, though, it has limited instrumentation. I use this robot. It's not my favorite one, but it has definitely application, mostly in general surgery, hernia surgery, gynecologic surgery, and some urologic surgery. It's available in UAE, in Lebanon, I think in Egypt. It's competing with the Da Vinci, but it has its limitation. The Hugo is another big system. So you can see the Hugo is also a system that is not FDA approved yet. It's a modular system, so every part system is separate. The advantage of the Hugo system is that it's cheaper in terms of upgrade. So the laparoscopic instruments can fit both the robot and the laparoscopy. When you upgrade the system, you don't have to buy a new system. You can upgrade parts of the system. It's not approved in the US yet. There are clinical trials going on. It's approved in Europe, but you can see the cost is not really cheap. It's around $2 million as well. We'll see whether it's going to, that's another Senhance robotic platforms, FDA approved. I have no idea about this robot, but it's FDA approved. The advantage of this system, it will track your eyes. So as you are moving your face, the camera can move with you automatically. And it has also haptic feedback. Now, those are the Da Vinci clones. And when I say clones, I'm not trying to make fun of those systems. Those are very capable systems, Chinese system, both of them. The Tumai or the Medbot, if you can see it, it's very similar to the Da Vinci system. They are trying to compete very aggressively against the American one. I use it actually, it's really very solid. It's the same experience for half the price. So those Chinese systems are trying now to enter the Middle East, African countries where the Da Vinci could not enter. If you compare those systems, as you can see, of course, they are all expensive, relatively speaking. They have some advantage, pros and cons. Of course, the Da Vinci is still the king of the robot. Now, let me shift right now to a different platform, which is the endoluminal surgery, because urologists and pulmonologists and maybe gastroenterologists will be interested in that. This is where the robot will go inside the lumen. Two big companies, Ion from Intuitive, the same like Da Vinci, and Monarch from Auris, are developing the endoluminal robot for bronchoscopy. So for pulmonologists, they do bronchoscopy using that. It can go. It is very proven and pulmonary approved, and they are trying to do the same now in urology for ureteroscopy, for example. Those are the two systems available right now. This is the Avicenna RoboFlex, which is a Turkish system available, not very cheap, but it is an endoluminal robotic ureteroscope, basically. The surgeon will sit on this chair. You put the ureteroscope inside the ureter, and you can move the ureteroscope with the help of joystick-like. It's good. I'm not sure whether it's going to replace traditional ureteroscopy, but this is already available and being utilized. I had the privilege of using this system. This is the Eli robotic system, very similar, French company. The Eli robotic system is compatible with many ureteroscopes, so you can attach different brands ureteroscope. You put basically, for the urologists among us, Ahmed and Ghazi, they know about that. So put the access sheet inside the ureter, you put the ureteroscope through the access sheet inside the ureter, and then you bring the robot, you dock the robot, and you use a joystick. Actually, it's a PlayStation joystick. It's developed by PlayStation, very similar to the PlayStation for video games. And you can move the ureteroscope in and out. You can flex it. You can move the laser probe in and out. And I use it for a big stone. Actually, it's effective. It's still expensive to buy. The consumables are not cheap. But for big certain stones, it's a very good system. Now, this is the latest system in endoluminal surgery, and I stole this video from a meeting because this is, to me, is the ultimate endoluminal surgery for urologists. You can see this arm. It has 3 arms. You can perform single-setting simultaneous ureteroscopy, and you can use PCNL. So this system is still not approved. It's still running clinical trial, and this is a video from a clinical trial. So you can see it can, if you are managing a big stone, for example, in the kidney, you can go with the ureteroscope inside, and then it will help you to make a puncture, find the stone, and you can have access from the kidney and from below using the robotic system. So what's coming in the future? Of course, the cost is always an issue. The cost control has to be. Now there is lots of competition, and with competition, the prices should go down. They are cheaper right now, especially with the Chinese market or the Chinese robot going into the market. So when the cost becomes controlled, I think we will see more and more hospitals and countries adopting robotic surgery. The haptic feedback, which is the feeling of the tissues, is there, is being developed. The simulators have to be better. I didn't show you the simulators, but the Da Vinci system has a simulator where you sit and you do like surgery in a simulation way. It's not very accurate yet, but it's getting better. Miniaturizing of the instruments, we are getting now with smaller incision, 6 millimeter instead of 8 millimeter, maybe go all the way to nanorobot. The superimposed reality is already there under development, where basically you are sitting and looking at the kidney, for example, and you are looking at the kidney tumor, and then you superimpose the CT scan or the MRI on the kidney, and as you are cutting, you are seeing the vessels, so it will help the surgeon to master the surgery better. Telesurgery is very exciting. It is coming. There are attempts done in Kuwait, there are attempts done in China with the Chinese robot. People are doing it right now. The surgeon in Kuwait is going to China, and he is performing robotic prostatectomy on a patient in the Kuwait. He has done around 8 cases, so it's doable and feasible, and hopefully it will help many problems we have. Of course, AI and automation will be the ultimate goal. So the ultimate surgery may be the end of surgeons, who knows? But as we are developing from freehand surgery open to minimally invasive laparoscopic to robotic, our goal, it will be surgery with full automation. Will that end our role as surgeon? I think no. I think a surgeon with AI and automation is going to be replacing a surgeon without AI and automation. But it will not be totally automatic. Now, this is some artist trying to imagine how robotic surgery could be in the future. This is a man with his wife attending a wedding on a remote island, and he got a call from his hospital for maybe emergency surgery, and he's doing that remotely, robotic surgery with the VR system. So that could be the future, who knows? Thank you very much. I'll be more than happy to entertain any questions.
Thank you, Dr. Madi.